Hello, hello. Welcome back to another episode of Red Pill versus Blue Pill. My name is Dr. Delon Canterbury. I am the founder and chief pharmacist of GeriatRx, where we focus on specializing in deprescribing harmful medications in our senior populations. I hope you guys are doing well and ready for this beautiful week. I am so excited today to share some common myths that I've found. So we'll talk about 4 common myths that I have discovered when it comes to stopping harmful medications in our senior patients. So as a part of this series, my task is to be your Morpheus and show you how to choose the red pill instead of the blue pill. The blue pill symbolizes maintaining the status quo, just basically being complacent in the ignorance of the system, where the system today represents, honestly, our broken healthcare system. So I want pioneers like you who are interested in becoming that next level advocate, the Neo or Trinity, if you will, to choose the red pill and unveil your potential in serving as a deprescribing advocate. So welcome back. This is the whole point and a personal passion project of mine where I've spent these last couple of years seeing seniors coming in and out of my pharmacy, working with them one-on-one, and learning how fragmented our system is. So I want clinicians, senior care providers, I want nursing homes, I want wellness directors, I want people who are touching senior patients to know that you can be the advocate to stop harmful medications. So I'll be your Morpheus, aka Delon, and we'll talk you through the ways that you can put this into practice right now. So here are some really common myths that I find when I'm telling patients, and more particularly senior caregivers and senior care providers, on how they can really stop harmful medication use in their patients. And they know they're coming in over medicated, they know they're suffering from side effects, but they have no idea where to turn or how to really get the ball rolling. So, first and foremost, the first myth I tend to hear the most is that people think that you have to be a medical doctor to literally advocate to stop the use of high risk medications. Now, of course, we know legally the doctor who wrote it is ultimately responsible for that patient's health and well being, right? We get that. However, you could still advocate for stopping harmful medication use if you're given the tools and the background and a team of people who are on your side showing you that there's evidence as to why this may be causing harm for your patients or your clients. So, yes, the doctor who wrote that prescription is ultimately responsible for making the decision to stop with the patient, but ultimately, it's the patient who makes the final say. Am I right? We wouldn't be here as healthcare providers if the patient isn't at the CEO of their health. So every decision they make, honestly, can start with you, the person who's touching the patient, seeing the patient, changing the patient, going home to help support them with PT or speech therapy. I mean, there are a number of ways that people in different clinical roles can be deprescribing advocates. And more importantly, leveraging the faculty at existing nursing homes and adult daycare centers is an immensely impactful way that you can roll out deprescribing services. So, yes, you don't have to be a doctor in medicine or really in pharmacy, even though it does help to have that expertise to stop harmful medication use in seniors. And I see it just from caregivers alone, caregivers who complain of the side effects, who complain of just unmet needs in their patients' well-being. And with their advocacy, led to the doctor deciding to stop or give a trial of a vacation to see where the patient may go. So again, there are different touch points in this system, right? Of course, you're going to want your trusted pharmacist on your team giving you all the benefits and all the lowdown on which meds or may not be appropriate. That's important. But again, you don't have to be an MD to make this happen. So you can literally put in the tools, and we will show you how with our Deprescribing Accelerator and put them into practice today. Secondly, people just assume that once you tell a patient, hey, this is an issue, I agree, I can see that you may be over medicated. Have you talked to your doctor about it, right? Again, I talk about passing the buck onto the patient. Yeah, ultimately, the patient has to have responsibility to take care of themselves, or at least their caregiver does for them. But again, we're putting the onus on the people that are most honestly frustrated with the healthcare system. They're the ones who have to deal with life in addition to worrying about the next visit, worrying about sending a note to the doctor, worrying about life in addition to managing the symptoms at hand. And well, sometimes just telling the patient to tell the doctor isn't always enough. And it falls either it just isn't as important, it's forgotten in the next visit, or maybe the patient just doesn't have the time or the bandwidth to really fully advocate. And I'll tell you again, this is myth number 2. You can be that advocate. You can have a team of providers, of a trained pharmacist, of people who are specialized in this space to give you all the evidence you may need to help support when it comes to addressing over medicating. So again, this is another myth that I feel is represented. They don't really know how to really ask, but most importantly, they don't think it's their job to do anything about their patients who are suffering from a bunch of meds. And this one is the myth that breaks my heart the most. You know, people who see a problem don't wait for a flat tire to become a car crash, right? You want to prevent any harm for your patients and well-being if you have the tools to avoid it. So passing the buck and just saying, well, that's not my responsibility, that's not what I'm here for. I mean, yikes, that's just waiting for something bad to happen to your patient. So I don't know about you, but I didn't get into healthcare to pass the buck onto someone else. And you have to, again, start with your mindset. Do you want to actively help patients who want to help themselves by being that voice for them? Do you have a system in place to communicate in a HIPAA certified, secure manner that can quickly get to that doctor's attention if need be, or nurse to communicate the urgency of someone being over medicated? Do you have a system in place where someone may be falling more than usual and you're able to see actual worsening of our patients' outcomes? How are you conveying that? We can show you how to do all this. Again, these are myths that I feel we have to change. You have to start leveraging your pharmacist. You have to start leveraging our specialty in geriatric care, but you also have to learn how there are tools that you can use to make this life a little bit easier for you, whether it be software, whether it be just having a system in place, or whether it be just having a form or questionnaire filled out that you can provide for the patient and then bring to the next visit if needed to discuss your concerns about harmful meds in our seniors. So again, these myths, you know, I hear them, but I don't buy it, okay? We can change this system together, and this is why the Deprescribing Accelerator is here today. So we're going to talk about why some of these tactics are wrong. Of course, we mentioned some people seeing that it's not their job to worry about their clients coming in left and right with 20, 30 odd meds, and you know, it's not my issue. So I don't see any additional revenue benefit or really any value added benefit. So you know what? I'm fine. I'll let them go on about their day, right? And that's flawed, guys. Let's be honest. We have to unveil the truth behind what we can do with deprescribing. We have to look at different revenue streams, okay? If you and your clinic are actively putting in some type of deprescribing workshop or some type of ongoing deprescribing service where you partner with a pharmacist, where you have trained clinicians mixed with administrative people who see the issue and you're able to track what you're reducing and what harm you're potentially avoiding and what costs you're saving on that patient's life or from a readmission to another hospital, then my friends, that is your selling point. That is your money maker. That is how you can not only grow your clients, but it's also how you can negotiate referrals with other local practitioners and providers who may want to have that added touch point of care. So again, this is all from just restructuring a little bit of what you're already doing to integrate pharmacists into this realm and grow your practice by showing you the ways how this can be a completely added revenue service. So again, you thinking it's not your job to advocate for deprescribing is an excuse, okay? If you're touching patients, if you're seeing people who are in harm's way, are you going to let them crash? Are you going to actively discuss what you can do to help them now before it becomes a, guess what, no patient, before someone may become a statistic, before someone may die, before someone's transferred to another unit because, hey, they now need assisted living. So we can prevent harm if we put the right preventative measures in place. And that's our job, is to reduce risk and reduce harm. That's why we're in healthcare, to make sure people have the best outcomes. So when people say it's not my job, it's not my role, well, one, you're missing out on an opportunity to grow your revenue. You're missing out on an opportunity to do what's actually morally good for your patient, right? I understand people's capacities are limited, but it doesn't mean you can't instill that fire to make change. And that is why we are really telling people to choose the red pill, because it's deeper than just your black and reds on an Excel sheet. It's more about what are we doing to change healthcare and improve care for our patients for the better. So again, why is that wrong? Passing the buck is no excuse. Passing on an opportunity to make money, to grow clients, to grow your practice, to actually change and have lasting impacts, that is something you can choose to do with deprescribing. Also, another myth is people fail to realize that there are costs that are direct and there are costs that are indirect. So when you are, say, working at your retirement community and Miss Lois comes in with her third refill delivered straight from the pharmacy, and for the third time in 2 months, she has fallen in your hallway. Who's going to get dinged for that? Yeah, yeah, exactly. You're going to get dinged for that. If this patient is falling religiously, if she's being readmitted, if she's having a fracture on your site, the onus is on you. And had you had someone in place to potentially prevent a falls, if it is medication related, then my friend, you're losing on that money on the back end indirectly because you are getting dinged for a potential Medicare patient who fell in your facility. So what does that mean? Each fall not only increases harm and increases, of course, the risk of fractures, but it also increases morbidity and mortality. And hate to be dark, but if your patient is dead, you're not going to get paid one way or the other. Okay. So finding the tools to not only get dinged from Medicare or other insurance providers when it comes to ensuring that patients aren't being rehospitalized, patients aren't falling left and right from your facility or your site, they're not suffering from chemical ataxia because they're just being sedated on antipsychotics like my grandma was, if you're not worsening dementia, if you're not putting measures in place to avoid risk, you will pay more on the back end. And my friends, this is why deprescribing is so critical. It's deeper than just stopping one or two meds. It's literally changing the way we talk about healthcare and our medication mindset as a whole. So it's wrong to assume that you just have to be this medical doctor or PharmD to be a D prescriber. Okay, let's get that out the bag first and foremost. It definitely helps to know those drugs and how the body works. However, you can be that advocate. And so there are tools you can use that are clinically focused, and there are some tools that are not clinically focused. Okay, a lot of this starts with having a conversation. When was the last time you've had an open conversation about your loved one maybe being on more than too many meds than really appropriate? Have you asked the patient? And sometimes they don't even know. Let's be honest. They don't know all the meds all the time. They don't know why they're taking them still. But what can you do to provide this needed service? What can you do to be that advocate, that de-prescribing advocate that they need so that you can, one, save them money, but also reduce risk? Again, the harm of inaction is what's going to drive you making some fatal decisions between your bottom line and what's best for our patients as a whole. So people think that because they're not de-prescribing, they don't see it as an important need, that, well, it's not my problem, so it won't affect me. That's where you're wrong. It can affect you, especially if we're talking about harm done in your facility, especially if you just have a zombified patient. You're reducing customer satisfaction. The family may notice. They may wonder why things haven't been up to par. I don't know. What I do know is there is more harm in you not proactively reducing the risk that patients may incur, which can lead to more costs for your facility and the patients on the back end. So we can fix this. Okay. Here is why these misconceptions just need to be thrown out the window, because we have to start seeing things from a proactive lens and instead of a reactive lens in our medication mindset. So first, we got to change our medication mindsets. We have to start teaching patients why overprescribing is a problem in our seniors. And this is exactly what our program will show you how to do and how to approach. We'll develop an easy to follow toolkit. We're going to give you the clinical tools needed. We're going to show you how you can start talking about de-prescribing today and put this as a potential marketing for value-added service for your clinic or setting, or again, as an empowerment tool for your community and your staff members who may have concerns about the medications their patients are on. So we also will work on talking through how your use in de-prescribing can actually be funded when it comes to some de-prescribing initiatives and grants. So we talk through how people not seeing that the money can be there is an actual possibility as a part of our Deprescribing Accelerator. The gaps in why people kind of think this way initially, I think, is just really coming from a place of not just one understanding what the heck a leveraged, well experienced pharmacist can do, but there's just a lack of perceived value in deprescribing, which is so ironic to me because we all know that people are coming into these senior centers with dozens of meds, with tons of side effects, and their bodies are not the same like they used to be 20, 30 years ago. And yet we're quick to prescribe another pill for another problem where we haven't even fully addressed if the meds are the problem to begin with. Again, I get lost why we jump to another med, and not see where some of the disconnects are in our patients' care and well-being, and just underlying an understanding of what they're getting into when it comes to these meds. So the lack of perceived value is what I think is a huge gap, and not seeing why these prescribing needs to be, frankly, the forefront of all of our healthcare. It shouldn't just be, for seniors. It literally should be for everyone. But we're quick to look for results and quick actions. So it's, again, I get it. Our healthcare system isn't perfect, but we got to get out of this mindset. We have to change the way people see our medications. So my process will walk you through not only understanding the barriers to deprescribing, but what has been successful. What are people doing clinically now with deprescribing at the forefront in inpatient and outpatient settings, okay? So it's not just a theory. We're talking about real life, real results where just implementing simple steps, simple communication streamlined had saved well over 80K in just 3 months in one study. And we've even had interventions where what? 73% of all pharmacist changes for a safer drug to stop were accepted by a provider. This was another study out here. So this is not impossible, okay? This shouldn't be someone else's problem. This is your problem if you're a senior care provider. What are you going to do to put deprescribing into your practice today? How are you going to talk through that? We're going to guide you. We're going to show you a team-based approach to giving this advocacy. We're going to provide you with the tools and pamphlets and worksheets and brochures that you can use to educate your community in mailers or in just weekly discussions or virtual talks, what have you. You can choose whatever method you want. We have to learn how to leverage pharmacists to not only help with the deprescribing portion, but to talk about genetic testing, to talk about how you can literally get your genes screened and tested and use that as a tool to stop harmful medications. We're going to show you how you can do that as well. Again, our Deprescribing Accelerator will walk you through the barriers, we'll walk you through the history, we'll walk you through which medications are most problematic for seniors. We'll also talk through specific topics such as opioid deprescribing, and we'll talk about deprescribing for dementia patients. So we're going to guide you along all this so you get the know-how, but in tandem, we're going to give you the steps to why and how you can use these tools today. So, I mean, it could be a clinical assessment, it could be our deprescribing toolkit brought to you by GeriatRx, where you have a personalized questionnaire for your team. Um, or we show you about the power of genetic testing and how you can leverage your pharmacist or nurse provider to literally start using genetic testing as a whole revenue stream as well to deprescribe. So the layers of variability and impact of our course can really move mountains, okay? We talk about the intro, we talk about PGX, which is genetic testing. We talk about growing your client base and revenue with deprescribing. And then we finish up with, of course, this is a 10-course module, but we finish up more with the patient advocacy piece and give everything full circle so you know you have all the support you need to put this into action right now. So don't believe the myths, don't pass the buck, don't think this is just another person's problem. And don't assume that you have to be a doctor of medicine to advocate for stopping harmful meds. My caregivers do it all the time. My patients do it all the time for themselves. So again, it starts with the right person changing our medication mindset. So thank you all for tuning in. I hope today was helpful and inspiring to show you that there is a way to deprescribe actively. And I'm telling you, you don't have to be a doctor of pharmacy like I am. I know it damn sure helps. But again, you can have the right tools in place, especially once you take the red pill. So let me be your Morpheus. Again, this is Dr. Delon Canterbury. Thank you for tuning in for another episode of Red Pill or Blue Pill. There'll be another one tomorrow. We will share some more tips with you on how you could put deprescribing into place. You guys take care. Thank you for tuning in. Much love, and I'll see you soon, okay? Have a good one.